We'll start. Does everyone see Pam's slides? Okay, great. Well, then we'll get started. Thank you for joining us for our fourth webinar on the National Trauma Research Action Plan. My name is Michelle Price, and I am the project co-principal investigator, and I am the executive director of the Coalition for National Trauma Research. The PI on our project is Eileen Bulger, University of Washington. However, she is on a plane today, so she's not able to join us. We are being joined by Dr. Craig Newgard, Dr. Elliot Howe, Dr. Zara Cooper, Dr. Jim Fickey, and unfortunately, Dr. Deb Stein has a conflict as well, so she has pre-recorded her presentation. We'll show that to you toward the end of the webinar. Next slide. So I've introduced myself. The National Trauma Research Action Plan, or NTRAP, as we all fondly refer to it, was funded by the U.S. Army Medical Research and Material Command. However, the views, opinions, and findings presented today are those of the presenters and should not be construed as official Department of Army positions or policies. Next slide. So today we are going to give a brief overview of Center and the NTRAP project. And then we're going to hear from 5 of our AIM 1 or Research Gaps AIM panel leaders. They're going to summarize the main findings of their panels. And then we'll wrap up by showing you where you can access the NTRAP resources and talk about how the data are available for secondary analysis and how you would go about asking for data. Next slide. So just a little bit on one slide on centers. The Coalition for National Trauma Research, or we go by the acronym CENTER, is a nonprofit research organization. We have partners, as you see on the screen, who are core, stakeholder, and affiliate members of our coalition. And they share in our mission, which is to enhance trauma research across the U.S. by advocating for sustainable research funding, coordinating research efforts across professional organizations, and enhancing the national infrastructure for conducting multi-site trauma research. Next slide. The catalyst for the NTRAP project is the report that came out in 2016 from the National Academies of Sciences, Engineering, and Medicine, titled A National Trauma Care System. And that report had 11 recommendations that they suggested we should undertake in the United States in order to achieve zero preventable death after injury. So the NTRAP project was designed to address 3 of those recommendations from the report, primarily recommendation 7 that you see on the screen, which is to establish a National Trauma Research Action Plan requiring a resource-coordinated joint approach to trauma care research. So the NTRAP project had 3 aims. Today, we're only going to talk about AIM 1, which was to perform a gap analysis of military and civilian trauma research to identify priorities across the continuum of trauma care. For more information on our other aims, you can go to our website, and I'll show you that location a little later. Next slide. So on AIM 1, we divided up the scope of trauma care into 11 large focus areas, and we recruited panel leaders with expertise in those areas to lead those panels. And you see the panels and those leaders listed here. Next slide. We set out to make this project as multidisciplinary as possible. And so when we were convening the panels to focus in these 11 areas, we reached out to the 18 professional organizations you see on your screen. And, depending on what their area of interest was of that society, we asked them, would you please recommend representatives of your organization to serve on the geriatrics panel? We asked the American Geriatric Society for that, for example, or for a rep from AGS to serve on the injury prevention panel. and so on with all of these organizations. Overall, we ended up with just under 500 subject matter experts, as well as patient advocates and patients who participated in these Delphi panels. So what is the Delphi method? For those of you who are not familiar with this, we used a modified online Delphi survey method, which is a way of having individuals present their opinions on a particular topic, and then through a series of survey rounds, they get feedback, they review feedback from other subject matter experts, and they have the opportunity to change their own opinions or responses based on the feedback from others. This has been used a lot with program planning and developing research priorities, including in trauma care. We opted to use the platform called SurveyLet, which is commercially available from a company called Calibrum. So this is a high-level slide of the process that each one of these 11 panels went through. There were a total of 4 rounds. In the first round, the experts were asked to generate research gaps, research questions, de novo, using in a variety of subtopic areas for that focus area, for that panel. Then we combined, curated all those questions. We provided each panel with a literature review that was specific to their focus area. And then in round 1, we had them go back into the survey tool, and they reviewed all the questions that were developed by everyone else on their panel. And they rated each one of those. And I'll talk a little bit more about that in just a minute. And then in the subsequent rounds 2 and 3, they went back and revisited their own answers and looked at the feedback from the other subject matter experts on their panel. Next slide. So in round 1, they looked at the research questions, and we asked them to rate each question in terms of priority. Like, if this question were answered, what would be the impact of having the answer to this trauma care question? They rated on a Likert scale of 1 to 9, 1 being low priority and 9 being highest priority. And as I said, they could also leave text explaining why they rated that item the way they did. Then when they came back into the system in rounds 2 and 3, they saw a screen like you see here, where there's the research question. They saw their own response up at the top, and then they saw the aggregate of all the other respondents on that panel and any comments that others had made about that research question. Then they had the option of adjusting their own score based on the feedback and the scores of the other panel members. A priori, we set a consensus rate of 60% or greater. So when a question reached a consensus of 60% or more, that question was considered complete, and it dropped off the survey. It did not appear in the subsequent rounds. So each time they had fewer and fewer questions to review. And the idea is that the consensus built on additional questions when they revisited and looked at the feedback from the other panel members. Next slide. So that's a very quick overview on our process. I'm happy to report that as of today, we have published the main papers from 10 of the 11 panels. The 11th is in the works right now. And all of these papers are available on the Journal of Trauma and Acute Care Surgery. They have a section for called collections. And if you click on collections, you'll see NTRAP is one of the collections that they offer. They're also available on our website, and we'll talk a little bit more about that later. And with that, I will turn this over to Dr. Craig Newgard, who led the panel on pre-hospital and mass casualty preparedness. Dr. Newgard?
Hi, everyone. Thanks for joining. Making sure everybody can hear me okay. Yeah, so just a brief recap to build on what you've already heard. We had a group of about 30 national experts who got together to generate a list of questions that better define what the gaps are in pre-hospital mass casualty trauma care. We went through the methodology that you just heard about, the DEFLI panel, to not only develop the questions, but also to score the questions and rank, prioritize the questions. Then out of this, we generated 81 high priority questions that I'm going to show you more about. Next slide. So you have an idea of the makeup of the panel. There were 31 of us. You can see it's about 40% emergency physicians, 40% trauma surgeons, about a third active trauma researchers, some intensivists, et cetera. Almost 90% of the panel had experience in the pre-hospital setting, and that was either as previous EMS providers prior to going into medicine, or EMS medical directors, et cetera. Most of the panel had some expertise on trauma systems, hospital-based practices, et cetera. Next slide. So as I mentioned earlier, there were 81 high priority questions that reached consensus out of this panel. Overall, the panel had generated just shy of 500 questions, but we're going to focus on the 81 high priority questions in the next couple slides. And this is just the top 5 questions. Really, all 81, I think, have similar relevance and similar importance for research questions in the pre-hospital trauma environment. But just to give you a flavor of what these questions look like. So just kind of run it from top to bottom. Does the administration of whole blood to critically injured patients in the field improve survival? Do lyophilized freeze-dried plasma and/or red cells reduce mortality in trauma patients with hemorrhagic shock? Optimal patient selection for administration of blood or plasma. So you'll see that this is a common theme. Blood product administration in the out-of-hospital environment was a common sort of topic for the questions. And then number 4 here, does TXA in the pre-hospital setting improve mortality and reduce disability? And then a follow-up to that, what is the incidence of adverse events related to TXA when given in the pre-hospital setting? Does it differ by age group, transport time, et cetera? So this just gives you sort of a flavor of what the questions, or some of the questions, look like coming out of this process. Next slide. So here I'll mention first that there was an overarching taxonomy that was developed for all the panels. So this included 9 categories relevant to these questions over all panels, and then a number of concepts. I think there were 118 total concepts that were then applied to each of the panels and the individual questions that reached the high priority status. So what we're looking at here is a list of the 46 concepts that rose to the surface in the pre-hospital panel, and then the number of questions on the y-axis. And this just gives you sort of a flavor of what the real dominant sort of topics or concepts were that came out of this group. I know the print is pretty small here, but this going from left to right focused on health systems of care, clinical interventions, studies that are focused on mortality, those looking at pre-hospital time, transport, processes of care, transport type is included there as well. Benchmarks, fluid and blood product resuscitation, training, et cetera. Next slide. And this just gives you a kind of a table look at the same figure, looking at the top 5 here. So health systems, interventional topics, mortality, time, system benchmarks, fluid, et cetera, and a few other ways of measuring the importance of those questions. Next slide. So the spider plot in the upper right corner is looking at sort of how this pre-hospital panel, the questions that came out of this panel, how they kind of penciled out in the context of 9 categories of research using that same taxonomy framework. And the front runner was focused on interventional study questions. So these other like histograms that we're showing here is basically representing under the interventional category, what was the order of concepts that came out of those questions. So looking from top to bottom, kind of the biggest drivers down to the least ones is fluid and blood product resuscitation, disaster management, operative intervention, palliative care, public policy, pharmaceutical intervention, and so on. So this sort of gives you an idea that if you were to look at these data in the context of what were the questions that rose to the surface that were really looking at an interventional study that could be done, a way of sort of rank ordering the importance of those questions that came out of it. Next slide. So I just have 2 more slides here. This is, I went back through the 81 high yield questions, and this is one other way of looking at the sort of content domains that really rose to the surface. So blood product administration in the pre-hospital setting was a very common concept that came out of these questions: how to manage hemorrhagic shock, or different ways of managing hemorrhagic shock, use of TXA, airway management. There were a chunk of questions that focused on older adults and specifically the processes of care, what types of trauma centers they should be transported to, what is the benefit of trauma care, bundled clinical care for older adults. There were also a number of questions that focus on trauma in the rural setting, and going down the rest of the list, EMS provider training and retention of skills, and then finally the system type, how EMS systems are structured, kind of digging further into that, field triage processes, when to activate helicopters, and similar topics. And next slide. So in closing, these are 4 ideas for how someone might use these data. So I'd say going from top to bottom, there's a very detailed list of basically specific aims that are buried within all these data. So if you were looking for ideas to drive a grant application, for example, this would be a great source of information to try to develop those ideas. From the funder perspective, it has a kind of a similar functionality of developing and looking for questions that might be pertinent to your organization that you would like to put some grant funding toward. And then for secondary analyses, how might someone use these data? I'd say if you're interested in very specific content domains or specific content or concepts, you could use these questions and the data that we've generated to sort, rank, and detail the questions on those topics. So, for example, if you're interested in studying hemorrhagic shock or the management of hemorrhagic shock, or blood product use in the pre-hospital setting, or systems of care, et cetera, you could use these data to rank those questions, go through those questions. We also set a specific kind of benchmark for defining what a high yield question was, or high priority, but there were almost 400 questions that fell into the middle priority group. So if you kind of lower the threshold, you would have more questions to look at. And then similarly, if you were focused on certain populations, such as older adults, or trauma care in certain regions, such as rural regions, you could take a similar approach to develop a kind of a rank order list of questions that could be used for a secondary publication to kind of drive the science on that particular topic. Thanks.
Thank you, Dr. Newgard. We realize we're having some technical issues here. The speaker window was being displayed. Okay, great. I think that's the right one now, Pam. We're going to swap that up real quick before our next speaker. Are there questions for Dr. Newgard? Okay, not seeing any at the moment. There'll be a chance for questions at the end as well. Okay, in that case, let's move on to our next presentation. Dr. Elliott Howe will be presenting the panel that looked at research gaps in trauma systems and informatics. Dr. Howe?
Sure. Thanks so much, Michelle. This is a great panel. I'm excited to hear the other parts as well. So I'm going to be talking today about the trauma systems and informatics paper. We were kind of published about 6 months ago or 7 months ago, at the end of December. Here you can see the visual abstract from the paper. And I'm going to go through some of the data similar to what we saw from Dr. Newgard. So next slide, Pam. So here's what our panel looked like. We had 37 members on our panel, and you'll see this is set up very similarly to the previous presenter. About 3/4 were trauma surgeons. We had some others, intensivists, informatics, researchers, burn surgeons. And as you can see, the area of expertise, most of us had some areas of expertise, including systems, trauma systems and informatics. Most of us were hospital-based, but we definitely had some experience in the pre-hospital arena. And then many of us were also involved in injury prevention. This is the top 5 questions that came out of the panel. I'm actually going to skip this slide because we're going to mention a little more of it later on. So what stood out? So we initially started out with 570 research questions, which is a pretty high number. We were able to achieve consensus on 75% of those questions. 209, about 50% of those were high priority. 213 were medium priority, and there were literally just a couple that ended up in a lower priority. So this panel really came up with over 400 high to medium priority questions ready to go on the topics of informatics and trauma systems. So what stood out to us? Obviously, because we're focused on informatics and systems, the healthcare infrastructure interventions really had the highest number of high priority questions. So 8 of the top 20 research questions were things like EMS capability. So this is in the EMS arena, but it's the system of how do you build the capability of what procedures, what do they have? Do we have blood, like we just heard about? Some questions were related to trauma triage and or transport, a little bit of overlap with the last speaker we just heard about. Some of it, and as you might imagine, this is really trauma system development, trauma sister placement. Where should they be put? What level should they be? What volume should be required? When can we put a new trauma center in a certain location? And does verification help patient outcomes? So these are some of the key questions as it relates to trauma system development. Trauma training. This had a little bit to do with one of the specific questions was, do patients treated at places or trauma centers that have trauma fellowships, does that make a difference? Or other types of training for trauma surgeons, but as well as other trauma physicians, whether it's in orthopedic trauma or whether emergency medicine or other arenas. The other piece, and this is near and dear to my heart as a guidelines person, was how can we implement best practices and or guidelines on a national larger scale as an infrastructure piece to try to improve outcomes. And then the last I thought was actually also very, very cool stuff. Part of what we looked at was informatics and this question of technology. What can we automatically put into the electronic health record? What can we pull out of the electronic health record directly into registries? Many of the trauma centers were using TQIP or NTDB or whatever. How can we integrate our EHR into all different systems? And this actually aligns with other parts of the NASM report about care across the continuum. How do we have data from the EMS to the in-hospital to rehab, to outpatient, et cetera. There were also some clinical topics that stood out, even in this area where we were looking at systems and informatics. A lot of the informatics questions had to do with diagnostics and monitoring. Which new devices have shown benefit? How can those new devices be integrated into better monitors? Can we link the monitors to other pieces of equipment, specifically into the EHR, et cetera? So those are some questions related to that. Blood and fluid resuscitation was another hot topic, as you might imagine, just related to the last speaker as well. Imaging, especially as it relates to, there were a few questions about artificial intelligence, new types of imaging and monitoring, transcranial Doppler, what other uses might it have? And then a few topics related to operative intervention. We were interested to know, as you know, the Nason report was a very much combined military-civilian report, and we wanted to know about our top 25 questions, which ones were which. So 11 of them were applicable to civilian and military. 10 were civilian specific, 3 were military specific, and 1 actually spoke exactly about the collaboration question that came up. So I think it really shows that, this is more of a civilian side, but there's certainly some of these things that are applicable in the military side as well. As it talks about phase of care, now not every single question had a phase of care tagged. Only a relatively small number had an area or phase of care mentioned. But of those times when it was mentioned most frequently, it was the pre-hospital phase, and that had 35 questions, of which 60% were high priority. So I wouldn't put too much emphasis on the phase of care being pre-hospital, because those numbers of all the types of questions that talk about the exact phase of care, not everyone had a phase, but when it was mentioned, pre-hospital is an important piece, just reminds us of the whole continuum of care for trauma. So what are the biggest gaps? Our questions, really, we look at the broad array. We had hundreds and hundreds, 400 questions. Many different interventions were identified. And it really was the overall ideas of the infrastructure and the technology, and using technology better to take care of patients, but also using technology better for education, using technology better for registries, and then quality improvement, and then becoming a learning healthcare system, using technology in real time for communication, all these other pieces. Education and training were important parts I already talked about, and then some of the clinical things of resuscitation and operative intervention. And then I already mentioned the pre-hospital piece. If you go to the next slide, so this is set up very similarly. And as you'll see at the top, healthcare infrastructure was the top item on this list. There were 89 questions, and then the proportions, well over half of those were high importance or high priority questions. And if you look at over to the other my right-hand side, the counts of these questions are significant. Well over 50 high priority questions just related to infrastructure are there. So if you really want to read it, of course, all of the data is in the paper and the online supplements with all of these questions and their consensus scores and their ratings and all these other pieces. But the ideas of infrastructures at the top, technology and innovation, I already mentioned, electronic medical record, database registry integration, patient monitoring, technology. These are the types of questions that we really looked at within our panel. So then the other question that goes along with it is, well, how will we answer these questions? And it was interesting for me to see as a health services researcher that, clinical trials are certainly an important thing, but the other types of research questions that we use are going to be really important. Studies about the systems of care, studies like outcomes research, quality improvement studies, epidemiology studies, educational research, cost effectiveness. These are the types of research that need to be done. It's not all just clinical trials. So if you go to the next slide, this was actually one of my interesting takeaways from this whole piece. And maybe I'm biased because I am a health services researcher and that's what I do. But it was great to see that we came up with lots of really good questions and made suggestions on the types of research that could be done that fall into this bucket of health services research. This is comparative effectiveness, health systems, outcomes research, quality improvement, guideline development, implementation science. All these pieces were what we thought as a group and that panel came up with of important ways to answer those important clinical questions. I think the next might be my last slide. So it's really this next question of what do we do next? Now that Michelle already told us that the main papers have almost all been published now, there's a lot of opportunity for these secondary papers to come out. So we recently wrote one about DVT and venous thromboembolism prophylaxis. Todd Costantini was the lead. And it looked at questions across all the NTRAP panels as it applies to VTE prevention. So I think the same thing could be done. Our questions probably overlap a lot with some of the others. I'm just hearing Craig Newgard's talk. There's other questions that I'm sure overlap with his panel. So these are the things where I'd love to see somebody look at trauma systems specifically or other panels. Did you have questions on informatics? How can we put those together into a more comprehensive, this is what all the groups decided is important for informatics, infrastructure, data integration, technology innovation, all these other pieces. You know, our group focused on it, but I'm sure there's lots and lots of other things related to that in the other 10 panels. So with that, I think I'm going to close and ask for questions.
Questions for Dr. Howe? All righty. Then we will transition to our next presentation. Dr. Zara Cooper led our injury prevention panel, and she's going to tell you about their main findings. Take it away, Dr. Cooper.
Great. Thank you, Dr. Price, and great presentation so far. So I had the honor of leading the injury prevention panel, and probably what I learned most from this is how much we don't know and how much work we really need to do around injury prevention. We had 29 members, a mix of trauma surgeons, researchers, intensivists, injury prevention specialists, and others. And we had a variety of expertise, including injury prevention, informatics, hospital-based practice, pre-hospital EMS, and then we did have trauma survivor and patient advocate representation, which I thought was really informative and very helpful in our process. Next slide, please. So as mentioned, our paper has already been published, and I would encourage you to go to the original paper to look at some more of the details. But I think there are definitely opportunities for us to leverage all of the Delphi panels in finding areas of cross-pollination and collaboration. What we found was that the most prevalent topic areas and high priority questions were around suicide, firearm violence, violence prevention, and that the NTRAP priorities differ from the CDC's in important ways, which is incredibly important when we look at opportunities for federal funding in helping guide funding priorities and funding policy. So I'm really proud of the work that we did. Thinking about firearm violence as a public health priority, which is probably not a surprise to this audience. Next slide, please. So the top 5 injury prevention questions were around violence prevention, as I mentioned. So the first one was, do programs counseling police and law enforcement officers regarding implicit bias and de-escalation lead to a decrease in police-related shooting compared to historical controls? I think we have some kind of empiric evidence, but we don't have high quality evidence around this, and that needs to guide our public discourse. How much does greater inclusion of hospital-based violence intervention programs and intervention specialists lead to cost savings through reduction in violence? Again, we haven't thus far really looked at the other implications of hospital-based violence intervention program. We've looked at recidivism at the individual level, but not how it affects larger communities. And again, regarding the HVIPs, are they associated with lower rates and lower sustained rates of violence in communities? For patients who present with traumatic injuries, does interactions with community service organizations while still in the hospital increase follow-up and compliance compared to initial contact after discharge? And one of the things that I think is really intriguing about this question is that we also had a panel about long-term outcomes and long-term follow-up, and this is a perfect opportunity for people who are thinking about these types of issues to develop synergies, as much as I hate that word. And then, does firearm technology reduce the incidence of firearm injury compared to non-smart firearms? And just thinking about ways that we can protect people who are using firearms to use them as safely as possible. Next slide, please. So what stood out, of the top 25 areas, 96% were around these three things. So, violence prevention, suicide, firearm violence. Unfortunately, suicide and firearm violence are closely linked. And so I think in some, we're trying to figure out how firearms can be less harmful to people who use them. Next slide, please. What are the biggest gaps? There's a consistent theme here around firearm injury prevention, comparative effectiveness for opportunities for firearm injury prevention, and then falls prevention. A lot of the interventions that have been tested at single centers or maybe in communities, but we haven't had large scale implementation. We have had some studies from PCORI, but there hasn't been large scale implementation, certainly across centers around evidence-based falls prevention programs. So I think there's a real opportunity there as well, and that perfectly aligns with the aging of the population. So according to our panel, when we think about closing the injury prevention research gaps, what's next? All research questions that reached consensus included the word firearm or gun. The top 5 topics were around public policy, mental health, clinical development and implementation, clinical assessment, and then technology innovations. And I think that technology, based on Dr. Hout's presentation, can reach not just into the technology for prevention for firearms, but thinking about the way we can use technology and electronic health records and systems to help us really track and mitigate the risk, and also to mitigate the impact of some of these events. Next slide, please. So what are ideas for secondary analysis within the panel data? What is the research agenda specifically for firearm injury? What is the research agenda specifically for suicide? And, which public policy interventions reduce the incidence of injury? As I said, we really, really don't know. And quite honestly, as we were, going through this process, it was remarkable how many questions were of, kind of moderate quality, because there's so little descriptive data about injury prevention. That many of the questions that we were asking were not actually hypothesis driven. It was just sort of like, well, what happens when, or do we know if? And so this is really for those of us who are passionate about this space, an opportunity for us to make significant contributions to patient care. Next slide, please. So I will conclude with that, and if there are any questions for me and or the other panelists and the NTRAP leaders, I will speak on behalf of all of us in saying that the NTRAP leadership and the center group were absolutely remarkable to work with, and without them we couldn't have done this huge project. So thank you very much, Pam, Michelle, and Eileen, for all that you did.
Thank you. Questions for Dr. Cooper? All righty, then we'll move along to our next presentation, which will be given by Dr. James Fickey. He led our orthopedic trauma panel. Dr. Fickey?
Thank you, Dr. Price. And I want to thank Pam Bixby and Eileen and the whole NTRAP group to to be welcome into the orthopedic sector. I want to and so I led the orthopedic panel, and I'll just, in the scope as we've done with each of the prior speakers, just talk. We had 31 subject matter experts, and we generated 506 questions in a wide array, from tissue injury to to hemostasis and even survival with pelvic fractures, as well as reconstruction of tissue organs. I'll go into detail about that. By round 3, we were down to 219 questions, about 43% of the total that reached 60%, the threshold for priority level. And interestingly, of these, we had 118 that ranked high priority, 111 ranked medium. We had no low priority. So I guess either everything's important to us, or we easily achieved a consensus. But I just would say that the group was comprised primarily of orthopedic surgeons, but we had some higher thinkers with us as well, some trauma surgeons, trauma researchers, and rehab therapists, and also we had some systems people to understand and to give some input on the orthopedic side of this. The piece that is important for this to understand is I'm going to talk a little bit off script, not with the context, just to talk about Major Extremity Trauma Research Consortium and a little background of that. But 22 of the 31 members were also contributors or investigators within the metric group. With the area of expertise, primarily large percentage were hospital-based practice, and practically every orthopedic surgeon, but also the trauma surgeons involved. And so we were involved and had experience with trauma systems, with long-term recovery, rehabilitation. We had military groups and civilian groups, and a little bit more civilian than military mix, but a predominant significant number. We had 17% that had published and had done research in injury prevention and pre-hospital care, as well as trauma survivor advocates. So the biggest gaps for orthopedics, I just, say as a side note, but a very important one, is the 2016 NASM report to prevent deaths and disability. The disability part is often undersold, but if everyone keeps the patients alive, how do we keep them functioning? And so the biggest gaps that we looked at in our panel were those that created disability or that created limits to ultimate function. And the biggest one was arthritis, to preserve function, to prevent or mitigate function, and even some of the substrates that might be biologic. Those of you who are familiar with the President Biden's recent selection of arthritis as the #1 topic for NITRO, or for the ARPA-H investment that he is supporting, and also preventing infections with these open injuries that are predominantly orthopedic surgery. The standouts that we had were, of the top 20 questions, there were only 2 actually that involved direct explorations into the impact of rehabilitation. And we know that as everyone prior to me speaking has said, there's a lot of pollination and collaboration opportunities. And I think that is essential for this to be successful, for the whole NTRAP to continue on, is to look at the rehabilitation panel and also the spine and neurotrauma panel, because we didn't have a lot of spine injury, but we also had orthopedic surgeons on the spine panel. And so the phases of care that were important and felt in the top 10 of those 6 involved direct inpatient care, 3 involved pre-hospital and resuscitation, and even some of the additional aspects on tourniquets and hemorrhage control and pelvic fractures, and then 1 question in outpatient care. The gaps that we saw, the predominant area of intervention clearly is the operating room. As the orthopedic surgeons, but to understand the context of this, the way the patient gets to the operating room made a big difference, and there was a significant number of questions in the pre-hospital care. Black on these diagrams are the convention we've all used, and that is the highest priority. Operating room was the most, and I talked about that and how so many questions that were of high priority and medium priority in that a far outstripped the inpatient non-critical care aspects. But you can see there's a distribution also from rehabilitation to emergency department. This is all of the questions, the 219 questions involved rehabilitation and also some of the critical care. And so now I'm going to talk a little bit about major extremity trauma research, or now as it's known, Rehabilitation Consortium. And this is a graph as of May this year. We've been enrolling for 14 years now into 47 U.S. trauma centers, including just virtually everyone that was involved with the NTRAP panels. 62 papers to date have been published from a cumulative enrollment of 22,800 patients across the United States. There are 173 total studies. Many of these are under review, and most of these have been revolving around gaps that were analyzed about 7 years ago, and then initially analyzed in 2005 as a relationship of military trauma and civilian trauma, and then how this congressional funding was able to extend the learning lessons from military into how do we explore those prospectively across the system, the country. And so that has been a driver for us. This is perfect. Thank you, Michelle. And these are topics. These are not questions, but these are areas that have been major multi-center studies, at least 30 centers in the ones that are in the blue that have all been published regarding compartment syndromes, amputee care, oxygen with respect to wounds. So we'll just leave this because that is our foundation of which we said, what are the next gaps? And for this, the timeliness of NTRAP to come in is important to be able to look at what else do we need to look at. You can go to the next slide. So the top 5 questions in orthopedics were sort of uniform. Targeted muscle reinnervation is a method that has been shown to have effective use in upper limb amputees to be able to extend the myoelectric prosthesis capability, but it's also being used in lower extremity amputees to provide a pain-free prosthesis wear. And so that's not really been validated. And that was one of our top question is, does that matter? Is it worth the time and effort and the extra surgery, the extra time in the operating room? But then the rest of these, if you can notice, are novel and validating comparative effectiveness type of study questions regarding infection and antibiotics and antibiotic administration for open fractures. So I wanted to go to the next 5 and look at the top 10, because that's where we start to see articular cartilage, the onset of post-traumatic arthritis. That's supposed to be osteomyelitis, or what do we do when bone has been infected? And then the other 2 are important because they're crossover and they give us opportunity for collaboration with trauma and resuscitative and even pre-hospital care with pelvic binders for pelvic fractures. So next, and this is really what's our future. I think the questions that we have to answer are fundamentally about infections. 12 of the top 20 questions were very, very thoughtful questions that reached consensus about infections, avoidance of infections, and then treating these. And then nerve regeneration, as well as nerve repair in the transected patient or the limb loss patient, and then post-traumatic, including potentially pharmacologic agents. And I would say that the question that ARPA Health is putting up as the first, quote, moonshot is, how do pharmacologic or biologic agents can we be applied to the event of post-traumatic arthritis to get people walking and replace those joints. And so I just, again, want to thank Michelle, Pam, Eileen, and all of the team. And I want to acknowledge all of the columns and the chance to give this this presentation to y'all.
Thank you very much. Questions for Dr. Fickey? Okay. We're going to move on to our last presentation of the day. This is Dr. Deborah Stein, who, as I mentioned, isn't able to be with us today. So she has recorded a brief presentation on the neurotrauma and spine research gap panel.
Just off the screen now. Okay. All right. Good afternoon, everyone. Good afternoon. My name is Deb Stein. I'm very sorry I can't be there in person with you all. But I am really, really pleased to be here to present the results of the neurotrauma panel for the National Trauma Research Action Plan. This is our visual abstract that we published in the Journal of Trauma and Acute Care Surgery. And obviously, similar to the other groups, we had an interdisciplinary group of experts in neurotrauma care and research, work to identify gaps in knowledge, generate research questions, and prioritize those questions using this consensus-driven Delphi survey that you've heard about. And basically, we were able to come up with 675 research questions, 364 of which reached consensus at a level of 60% or above. 15.4% were high priority, 83% medium priority, and only 1.4% low priority. I will say that for the purposes of our group, we did kind of divide up those research questions into three groups, one being severe traumatic brain injury, one being mild traumatic brain injury, and the other one being spinal cord injury, just because those questions are so different and so diverse, and it was really hard to lump those all together. Oh, excuse me. Our group was compared. You can see the composition of our group, the neurotrauma panel makeup. 33% were neurosurgeons, 30% intensivists, and you can see down the list there. Most of us were in hospital-based practice. Some of us were in trauma systems and informatics, and a couple of long-term care providers as well, and a few injury preventionalists. And basically, our top 5 questions were, not surprisingly, I don't think to anybody who's lived in this world for any period of time, is going to be, does autoregulation for management improve outcome in severe traumatic brain injury? Does a personalized approach to TBI care with respect to ICP targets alter outcomes? Does continuous EEG monitoring improve outcome after severe TBI? Are there sequences in MRI that would be more effective for prognostication than what we currently use or are currently routinely used? And then are there TBI-specific biomarkers that can be used to generate an overall what we call biosignature or subcategorization of individuals with similar TBI pathologies to help guide our initial imaging, our examinations, serum biomarkers, et cetera? And I'll go into a little bit more on detail on each of these. And like the other panels, we took our questions and we did divide them up by the NTRAP's taxonomy. And you can see that the most infrequent types of taxonomic concepts that were interventional or comparative effectiveness trials, that was most frequently assigned to our research, to our panel's research questions that reached consensus. Outcomes research was a distant second to that. Our interventions that were most frequently assigned included patient monitoring, pharmaceutical therapies, and imaging. And what was really interesting, but not surprisingly to those of us who do this work for a living, the outcome of interest was really functional in nature. In fact, mortality as an outcome measure was not recommended in any question, which really highlights the concept of that traumatic brain injury and spinal cord injury, but particularly traumatic brain injury, is really much more than just lived or died. It's very much a matter of how did the patient ultimately do from a functional outcome perspective. And I think that that's a really important thing to highlight. When we looked at severe traumatic brain injury, again, dividing it up into those 3 categories, severe, mild, and spinal cord, the research questions about personalized and optimal monitoring strategies really dominated our entire list. The things that were felt to be extremely important investigations for further research would be defining optimal cerebral perfusion pressure and pressure reactivity indices, evaluating how to optimize these cerebral perfusion and pressure reactivity, and the role of ICP targets based on individual patient characteristics, age, or lesion size. This theme of specificity in monitoring came up a couple more times with respect to high priority prioritization of biosignatures, the role of multimodal monitoring, as well as the ability to better prognosticate, particularly with either biomarkers or with advanced imaging such as MRI. Additionally, a kind of a separate theme that emerged was this concept of some geriatric specific questions, particularly around the ICP monitoring, but also other questions around geriatric or older adult specific questions that people would like to ask, given that many of our current TBI research really doesn't focus on those individuals, and that disease tends to be a very different disease than it is in young people. With respect to mild traumatic brain injury, the NTRAP taxonomy assigned categories for type of research outcome were similar to that for the whole panel, but phases of care and interventions were prioritized a little bit differently, not surprisingly, given the difference in mild versus severe traumatic brain injury. The most common phases of care addressed were for our research questions were in the pre-hospital environment as well as the emergency department. And the interventions that were most commonly highlighted were imaging, physical examination, laboratory measures, and patient monitoring for most of our high percentage of high priority questions. Spinal cord injury was a little bit different. The research questions primarily focused on operative interventions, technological solutions. A lot on rehabilitation was really highly prioritized. And about 50% of the patient monitoring research questions received a high priority assessment. And what was really interesting about this group of questions, research questions, remarkable consistency with respect to the highest priority spinal cord injury research questions. So we really kind of came into focus on that and was able to consolidate around a bunch of really important concepts. This is just graphically demonstrating a lot of what I've been talking about. Clearly, interventional clinical trials and comparative effectiveness really dominated our taxonomy. And you can see here for traumatic brain injury in the in-hospital critical care setting, which was obviously different than it would be for mild traumatic brain injury, since those patients don't ever make it to the critical care setting. So we talk about what the biggest gaps are, what the most important questions to answer. I think it kind of summarized for severe traumatic brain injury, this concept of individualization of monitoring and biosignatures really was super high priority amongst the group, as well as this issue of how do we manage patients with severe traumatic brain injury later in life or our older adult patient populations. With respect to mild traumatic brain injury, it's really the questions were really around detection and imaging. And then for spinal cord injury, kind of a very different focus was really on surgical management as well as high quality rehabilitation. Lastly, some ideas for secondary analyses within the panel data, and I will tell you that some of this work is ongoing now. One is to figure out how to prioritize traumatic brain injury and spinal cord injury across the different domains from all the NTRAP groups. So how does that kind of dovetail in with what the critical care group was doing or what the prevention group was doing, and where can we find areas of common synergy? The other thing is to really do a much more detailed subgroup analyses of severe traumatic brain injury, mild traumatic brain injury, and spinal cord injury, rather than lumping together, but really do some splitting there to see if there's some signal in there that can really help guide our research efforts going forward. I'll close there. Again, I thank you for the opportunity to be here. Very sorry I can't be here in person, but if anybody would like to reach out to me, please feel free to contact me. Happy to answer questions or collaborate with anybody who has ideas about how to utilize this data to better do better research and ultimately prioritize better outcomes. So thank you.
Great. So with the few minutes that we have remaining, and while Pam is swapping up the slides, I'll tell you a little bit about all the resources that are available to all of you to use this treasure trove of research priority questions. On the center website, which you can get to the website using that bit.ly or the QR code if you want to snap a quick picture of that. On our research tab, we have several pages that are just for this project. This is where you can find all of our articles. You can request data, and you can also learn about the taxonomy, which we really haven't covered here, but has but it has been referred to. We wanted to make it easy as possible for researchers to look at questions across the panels in secondary analysis. So all of the consensus reaching questions have been tagged with the taxonomy. If you'll go to the next screen, Pam, the next slide. This is not all of the taxonomy, but what you see is like you can look at it by the type of intervention that question would require, the type of research that question would require in order to answer it, the population, and like I said, all of the consensus questions are tagged like this, so it makes it really easy to do research across the different panels, like the VTE prophylaxis paper that Dr. Hout mentioned. Next slide, please. And then our data access form is here. You just fill out a couple of quick questions about what data would you like to use, which panels, what are your hypotheses, and hit submit. we, and you can go on to the next slide. We are making data available 1 year after the primary paper is published. Unless the investigator served on a panel, then the embargo does not apply. Or if you're partnering with someone who served on a panel, same thing, no embargo. We take those requests to our NTRAP Publications Committee. They review them to see if it's an appropriate use of the data and to make sure that someone else isn't already answering that question. If it's approved, then we turn that request around in a month, and we have the investigator sign a data use certification, how they can use the data, our expectations in terms of like acknowledging the panels, bringing the papers back to our publications committee before they're submitted for publication, just to make sure that the data are being used in the way that they were intended. Next slide. So that is a quick snapshot of what's available online. That's why we're doing these webinars, is because we want folks to understand what is potentially available to them, whether they're writing a grant or developing a line of research. We are just 1 minute before the hour, but if there are any questions, I'll be happy to entertain them. All right, well, thank you again to all of our speakers for presenting today, and also for leading your panel. I know it was a labor of love, and it's hard to believe we've been at this since 2017 and it's fine. We're actually wrapping up the study officially on August 1st. So it's been great working with you all, and please think about secondary analyses and reach out to us if you need more information. Thank you very much, everybody.